Medications for opioid use disorders in correctional settings. Shifting the paradigm, creating a balanced correctional and rehabilitative approach. The Opioid Response Network is funded by SAMHSA to provide resources and technical assistance needed locally to address the opioid crisis. This video is part of a series to provide guidance on the implementation of medications for opioid use disorder in correctional facilities. Leading corrections and behavioral health experts present information on topics such as the use of medication, models of delivery, diversion, and linkages to care and community support. An interview with Ross McDonald, New York City Health and Hospitals Correctional Health.
My name's Ross McDonald. I'm the Chief Medical Officer for the Division of Correctional Health Services of New York City Health and Hospital.
How do clinical staff in correctional settings respond to the idea of MOUD?
There are some challenges in corrections around MAT. Some of the stigmatization of those treatment modalities that has occurred in the community are potentially more ingrained in criminal justice settings historically. There is a tradition of working to keep drugs out of these facilities. And so there can be some inherent tension between health staff and security staff around these issues. I think the most important lesson from New York City, which has operated an opioid treatment program inside the jail system since 1987, is that those tensions can be worked through. And really, we've gotten to a place in New York City where this is not a controversial program. It's a fact of life, and everyone, corrections and health together, support it.
What can clinical staff expect with the implementation of MOUD?
Again, it's hard for me to advise people on implementing a program because I had the good fortune of inheriting the nation's oldest and largest jail-based opioid treatment program. But what I can say is that we know the endpoint is one of stability, one of collaboration, and we know this can be done. I think there are a lot of fears about change, particularly when introducing new medications to the facility. And I think a big part of our role is to calm those fears by saying it's possible. We've been doing it for so many years that we know that it works.
What are some of the positive impacts of having a well-run MOUD program?
We think that it improves the way the patients feel. We know that as physicians, that the treatment of withdrawal, as well as the treatment of dysphoria that's associated with long-term dependence and addiction, improves behavior. There's evidence that it reduces the risk for suicide and homicide in these facilities. And so we think that that fits with our anecdotal experience, that when you treat people with the right medicines based on the clinical need, that their behavior improves, and the end consequence of that for everyone in the facility is that your day gets a little bit easier. The facility's easier to run, the patients are easier to work with and to talk to because they feel better.
Given these positive impacts, why is there still so much resistance to implementing MOUD?
I think the stigma is an element, but it's not the only element. Implementing programs anywhere is a challenge, and implementing programs in corrections is a particular challenge. These are very complex human institutions. So jails are complicated, prisons are complicated, and healthcare delivery is complicated. And when you superimpose healthcare delivery on one of those places, everything you do is challenging. So all of the elements that you need to think about, all of the things that you need to troubleshoot in order to implement a program like this are very daunting. So if you have all of those challenges and barriers, plus you have stigma, plus you don't have a mandate to do it, it simply is not going to happen. And that's why in most facilities, for those 30 years from the time that our program started, it hasn't happened. I think what's changed is that now there is a mandate. Now there is a shift in the stigma. And I think that many facilities around the country are starting to see that this is very doable and it's the right thing to do.
How do you discuss and address the concerns of staff about diversion?
First, I would validate their concern. So diversion is a problem. It's a thing that does occur. And any successful program has to expect it and to have mechanisms in place to deal with it. But I would also say it's a problem that can be managed. And really, it comes down to collaboration between health staff and security staff so that these medicines are given in a controlled way, so that patients are observed when they're given the medication, and diversion can be minimized through effective policy.
What is the connection between substance use and recidivism?
When we've looked at the most frequently incarcerated patients who come into our care, importantly, this is before a lot of criminal justice reform in New York City, what we saw historically was a tremendous cycling of patients through jail, such that a group of 800 patients accounted for over 16,000 incarcerations in a period of about 6 years. And when you look at what's going on with those patients in particular, substance use rises to the top. Significant substance use was present in almost 97% of those patients. And really it speaks to the way that we as a society respond to issues of substance use and the limitations of a punitive response. So these are the kinds of data that can help systems and our society start to think more carefully about the way that we use punishment when it comes to addiction.
Have you seen a reduction in recidivism since implementation of MOUD?
Recidivism is a really challenging endpoint to measure. What we have seen is big changes in the criminal justice system and a relative decarceration in New York City, so that there has been a large decline in the jail population. And that has disproportionately affected those with substance use, which we think is a good thing from a medical perspective, because we see that incarceration as a risk factor for overdose death for those patients.
What else would you like to share with facilities considering an MOUD program?
As far as words of wisdom for a system that's trying to implement a program such as this is that it will be okay. It may be a challenging process. Jails are complicated places, and anything new we do is hard. But we know that this is not a Pandora's box. We know that it can be done, and we know that in the end, it has to be done to provide the right care for these patients. And there will be ancillary benefits, including we think that the facilities will be easier to manage and that people will be at lower risk, both of overdose when they leave, but also of suicide and problems of violence in the jails.
Technical assistance is available to support the evidence-based prevention, treatment, and recovery of opioid use disorder. To request technical assistance, visit opioidresponsenetwork.org.